So, welcome again to Addressing Pediatric Feeding Disorders in the School. Today, we will be talking about utilizing a team approach. I am Jennifer Eggert, Clinical Assistant Professor and Speech Language Pathologist. I am coming to you from my home, but usually I'm working at Marquette University, or I also do see patients at a private clinic. I wanted to start by going into, thank you, Dawn, for the next slide. I wanted to start by just going into a brief review as we've been building each session and talking about the fact that we first identified what is pediatric feeding disorder. And then our last month, we talked about the fact that students with PFD have a right and need to participate in meal times at school. And this participation factor is really what has driven a lot of the work that we're doing here. I had come up with this little visual here talking about student participation, student safety, legal implications, and ethical considerations, and trying to show the interaction between all of them, and that it is rather complex, and that again, we are looking at children who have pediatric feeding disorder and are impacted from a medical, nutritional, feeding skill, and psychosocial standpoint. So let's go to the next slide. And even though we have students with PFD that have a right and a need to participate in meal times at school, we need to remember that what's most important in supporting them is going to be that team approach. And that team approach will be vital to successful implementation and to their participation. And here we have another visual where I'm trying to show you again that interaction between the student and their caregiver or caregivers, outside medical providers, and the school district and their personnel. So again, want to remind you all that we are not coming here to teach you how to do feeding and swallowing therapy. We're not coming here to teach you how to assess children and to be able to give a diet recommendation. We do want this to be a team approach, and we do want you to rely heavily on your outside medical providers and the students and their caregivers so that you can very carefully and safely implement things within your district. Your job is really to be a carryover person. Now, some of you may have very, very strong skills in this area, and that's wonderful. You are ahead of the curve, so to speak. But we do, again, want to recognize and stress that the majority of school practitioners may not feel that, even though this is within their scope of practice, that this is within their field of expertise or even field of comfort. So on the next slide, we're going to talk a little bit about team formation. And team formation and teaming and leadership is just really one of my favorite topics. I love this idea of team formation being forming, storming, norming, performing, and adjourning. And this is just a visual that I got from LinkedIn. There's a lot of different ways to look at this, but the bottom line is that we're looking at teams coming together and forming, teams acquainting and establishing ground rules, formalities being preserved, and members treated as strangers. We're starting new. And think about that at the beginning of your school years or any time that a new person comes into the district or into your building. And then we get into this phase of storming. And storming is when members start to communicate their feelings, but still view themselves as individuals rather than as part of a team. And they really resist control by group leaders and show hostility. So we're sort of seeing this curve of we come together, now we're going down, and then we're going to go back up here into norming. And norming is when people feel that they are part of a team and they realize that they can achieve work if they accept other viewpoints. And then we get to the highest peak on this curve, which is performing. And performing is when the team works in an open and trusting atmosphere where flexibility is the key and hierarchy is really of little importance. Now, at some point, whether it be the end of the school year or the end of, say, an IEP, or maybe somebody's leaving, you can have the team adjourn. And that is when the team conducts an assessment of the year and implements a plan for transitioning roles and recognizing members' contributions. Now, that doesn't always happen formally. Sometimes people just leave mid-year. Sometimes individuals may be taking a temporary leave. Teams may just be shifting. But again, if we look at this model, I think it's really, really useful for us to think about the teams that we work on and where are we in this team formation? And do we recognize that the forming, storming, norming, performing, and adjourning happen again and again? And sometimes we fall back. Sometimes a person leaves or a person adds to our team, and then we have to go back to storming before we get to norming and performing. So really, really useful for us to think about team foundations and team formations. So in the next slide, we're going to look a little bit at effective teams. Now, thinking about effective teams here, I pulled up a source that I really liked this example, but I will read through it in a moment after I remind you that interprofessional education and interprofessional practice really involves knowing and understanding the roles and responsibilities of each team member and how to collaborate and communicate. So in this, professionals are aware of roles, but working towards shared goals, in this case, of safe meal times. Professionals are willing to give and receive information, and they are open to suggestions and problem solving. Team members recognize their own personal professional limitations, and open communication in all of this is the key. So in terms of effective teams, a good team knows why it exists. The purpose is relevant, meaningful, and clear. And I think we can all think of examples where we've been put on a team to do something, and we know we have something to do, but we're not really sure we know what to do, or how to do it, or what the end goal is. So a good team should really know why it exists. A good team creates a space for learning. Members can make mistakes, take risks, and ask any question. It should be a safe space. In a good team, there's healthy conflict. There's constructive dialogue and dissent. And I think that that is something that can be uncomfortable. There's a great book out there called Difficult Conversations. And if you're really interested in team formation and teaming, I highly suggest it. Number 4, members of a good team trust each other. And this doesn't happen overnight. We know that. This includes equitable participation among members, which we also know doesn't always happen. And sometimes we have to help facilitate or encourage, and shared decision making. And a good team has a facilitator, leader, or shared leaders. And that can be really important, even if it's simply for the task of keeping us on schedule and making sure that we know what we're doing, making sure that we have an agenda, etc. So a lot of things to think about when we think about effective teams. But on the next slide, we remind ourselves that the most important team member in every model is the caregiver or caregivers and the students. And this also includes extended family members and siblings, perhaps. One of the important considerations in thinking about this team member model and having the caregivers and students of as part of this is that we are considering the student and caregiver culture as it pertains to food choices and habits, perception of disabilities, and beliefs about intervention. Now, this little statement right here by Davis and McFarland could be an entire presentation or an entire class in and of itself. And I know that we all strive to be DEI aware and always learning more. But I think it's always a good reminder to think about diversity and inclusion and being equitable and including the culture when we think about the individuals that we work with. So let's compare models here real quick. So we mentioned the medical team model, and the medical team model is that model that, again, we know that they have a very important role in this paradigm that we're looking at, in this partnership that we're looking at. We're really going to rely on them a lot. The medical team models are quite different from ours, though, and I think it's worth a moment to compare them. So inpatient teams and medical teams involve perhaps a neonatal intensive care unit, which you may hear referred to as a NICU, or a pediatric intensive care unit, which you may hear referred to as a PICU. There may be a home care component, which could include private duty nursing. I'm curious how many of you work with private duty nurses or have private duty nurses that come to school with your students, or that you know are hired by the school district to work with different kids. For example, a lot of time, anytime you have a child with a tracheostomy, they will have a private duty nurse with them. And then we can also look at medical teams from an outpatient standpoint. And outpatient teams typically occur within an outpatient hospital clinic or even within a private outpatient clinic. For example, I work at a private outpatient clinic. So each of these medical teams is a different model and they have unique characteristics within them. But again, what's really important about this medical team model is that they have that medical component to them. And so in the next slide, as we're going to see, they have different team members than we have. And that's really important for us to recognize the importance of those team members. So of course, the one of the main medical team members is going to be the primary medical doctor. You may see that printed as PMD. A physician's assistant is often in place of that, or a PA, and then you may also sometimes see a nurse practitioner or an NP. We, of course, have speech language pathologists, occupational therapists, and physical therapists as part of that team. But then we have this whole slew of specialists. And this can include GI doctors, otherwise known as gastroenterologists, pulmonologists, which are our lung doctors, cardiologists, which focus on the heart, neurologists, which focus on the brain, geneticists. A lot of our kids go to geneticists, otolaryngologists or ENT, ear, nose, and throat doctors, dietitians, psychologists, the list goes on and on. It's really, really a blessing to be part of a medical team where you have access to all of these individuals. And I know from having worked on medical teams that we want you to be a part of our team too. And they do want you to reach out. They do want you to ask questions. They do want you to help facilitate conversations. The medical team has some different responsibilities than what the school team does. So let's take a look at that. For students or children with PFD or pediatric feeding disorder, the medical team is responsible for assessment and intervention related to medical stability for feeding, assessment of weight and overall growth, determining caloric needs and how those needs will be met, whether that be through a supplemental intake. So for example, could that be some high caloric drink? Or could that be a different route of administration? Could that be a G tube or a GJ tube, a gastrostomy tube? Assessment of feeding skill safety, both clinically and instrumentally. So in terms of clinically, we can call that a clinical bedside, where you are sitting with the patient and looking at what they look like just as you're sitting there in person. Or instrumental, there's a number of assessments which you may or may not be aware of, including video fluoroscopy, which is done under X-ray. And then there's also a procedure called FEES, which is basically where you take a very, very, very small microscope and insert it through the nares or the nose, and you can see the swallow from above. They both give you different information, but they are both done within a medical facility. Determining appropriate adaptations for positioning, feeding utensils, temperature, taste, texture, bolus size, and presentation or pacing. How fast or slow are you offering that food? It's all things that medical team can be responsible for. And then also overall, generally in the assessment and intervention in the psychological domain. Now, how these team responsibilities are differentiated depends on the team. I've been on teams in hospital settings where each role is very clearly delineated based upon the professional, and they will come together as teams. That, for example, Children's of Wisconsin here in southeastern Wisconsin has an entire feeding team where they have a dietitian or a nutritionist, they have a speech pathologist, they have a nurse, they have a primary medical doctor who sees the children, a GI doctor, etc. I've been on home care teams where I have a nurse that works with me, and the nurse is responsible for doing weighing and measuring and ensuring safety. It just really depends on the setting where you are at. I've also been in hybrid teams where I'm seeing these child as an outpatient, but I'm sending them to even another place for further instrumentation and then sending them back. So again, it takes a lot of coordination and a lot of collaboration. And I want to recognize that because it's really important. We know that this is time, and time is precious to all of us, no matter what setting you're working in. On the next slide, again, we're going to focus on the idea that school teams are not medical teams. And your responsibilities, as we've stated from the day one of the start of this presentation, and I've mentioned several times today already, is that you are responsible for the carryover and implementation of medical recommendations within the educational setting for participation in mealtimes. And this includes hydration and caloric intake. Again, I want to recognize that some individuals in districts may have different skill sets and they may feel more comfortable with helping with some of the assessment and intervention part. But I want to reassure you all that we are looking at a foundation of you being responsible for carryover and implementation of skills that have been determined by a medical team or personnel who feel that they are skilled in this area. So now let's look at what you're all familiar with, which are those examples of teams within the schools. Now, there are different school team models out there, and I'd be interested if you want to pop it in the chat, what kind of team you have in your school, if you have one. So there are some where they have the in-house or on-site team. It's the individuals that are in that actual building, and they are responsible for everything. Some districts will have a team where it's shared personnel and they go between schools or go between buildings. There are districts where they use a consultant or contract. Consultants could be specialists in feeding, or it could be a contract. Maybe they have a contract with a staffing agency. And I assume that most districts or many districts will have sort of a hybrid of some of these approaches. So just peeking at the chat here to see, I don't see anybody popping anything in. Okay, so we have here some examples of in-house, now a contracted consultant, some hybrid. I'm excited to see the variety that reaffirms what we've been reading. In-house and on-site, in-house mostly. Yeah, I think there's a variety of things, but it seems to be that there's a lot of individuals that are in-house. Hybrid. Thanks for sharing those. Keep popping those in because I think that's reassuring for others to see. In terms of school team members, this is going to look different than the medical model. In the medical model, we had all of these medical professionals. And of course, in the school team model, we have all of our school professionals. You guys know who you are. Individuals who are speech language pathologists, occupational therapists, physical therapists, our special and regular ed teachers, paraprofessionals, administrators are part of this rule. We're going to talk about administrators throughout this series and the importance that they play. Paraprofessionals, the school nurses, our nutrition team members, and then our school social workers or counselors if you have those on site or within the district. So again, I want to throw this in the chat here, thinking about who are the core members of your feeding team, if you have one in your district, if you have a designated feeding team. Who are some of the core members of your team? And I'm asking this because I think it's really useful for us to share and remember that it's important to have a team leader to oversee the process. We need to identify, though, who are the members of that team, who's most likely to be the team members, and then that we have some procedures that are followed with fidelity and team members are kept informed while processes are documented. So here I'm seeing some different things in the chat. Nursing and CHAs, I have to admit, I don't know what CHAs are. Speech pathologists, nurses, OTs, and paraprofessionals. Nursing, OT, speech, and the special ed teacher, a certified health assistant. Here we have a team that's the school nurse, special ed teacher, and the paraprofessional that help care for the student. So in that team, the speech pathologist isn't even part of that team. So it's so interesting to see the makeup of all of these different teams. A certified health assistant. Thank you, everybody. Yes, I remember learning about them now. The school nurse, special education teacher. Oh, currently just a nurse. So there's Shelley is sharing that currently their district just has a nurse that is in charge of all of that. And again, these are all different models that are used, all different members. Okay. Now let's look at the roles and responsibilities of the team members. Everyone on the team, every single person on the team can act as a referral source. Everyone on the team is responsible for safety and ongoing assessment of procedures and student response to mealtimes. Everyone on the team is responsible for providing education to caregivers and to other professionals, and everyone should be responsible for documentation. On this slide, I put our little saying, if you see something, say something. And I think that that's something that we have come in to our common vernacular now in terms of just other safety things that we've become aware of within school districts and within society in general. And if you see something, say something really, really applies to children with pediatric feeding disorder. You just never know what one little thing you're going to say to somebody that might be an important piece of information. So I was at a team meeting today and somebody was mentioning that the child was staring and that they were just staring and then they would kind of snap out of it and then they'd keep eating. And a lot of individuals were thinking that this little person was just sort of zoning out for a second, taking a break, chilling out. Somebody said something. And another person heard that and said, wait a minute, are they having stare seizures? And sure enough, that child just got diagnosed with epilepsy. So again, any little piece of information that you have about a child can be a part of a big puzzle. Okay, so now what I'd like to do is I'm going to go into a couple of notes here about roles and responsibilities, and then I'm going to pull in some of my team members here. So when we're looking at roles and responsibilities of our team members, we should always go back to the considerations for the scope of practice and competency. Again, I'm a speech pathologist, so I keep bringing up this example of speech pathology and that we as speech pathologists are trained to provide assessment and intervention in 9 different areas. We call them the big 9. Feeding and swallowing is one of them. However, just because you're trained in it doesn't mean that every speech pathologist that you interact with is going to feel competent in it. I think it's the same with occupational therapists. Not every occupational therapist feels like they are a specialist in sensory integration. Not every physical therapist that you meet is going to know how to do serial casting on a student or a child. So it really depends on your competency and what different continuing education you have gotten. In any profession, when you leave school, the job of that school or educational setting is to make you minimally competent to provide services. And then as a professional, it's our jobs is to go on for continuing education, just as you're doing today. So the scope of practice will be the same across professions, but the competencies will look different for each team. And this can change over time. That's what's so exciting about this. It's dynamic. So there will be individuals who have gained experiences. There will be active mentoring occurring, maybe training, and then there could be role release. So role release being the idea that, say, I am the speech pathologist in a school, and I've really been working hard on ensuring feeding safety for a student, and now I have worked to actively mentor and train the paraprofessional. And that paraprofessional really does beautiful job with that student, is completely independent, and I can release myself from that role. I don't have to see that child maybe now for feeding sessions anymore. Maybe I'm working on speech and language and I'm checking in on feeding. So role release is something that's really important in a team and seen when you have a team that has trust with each other. I also want to remind us that competency is not a single course or certification. So there's a lot of these different certifications out there. Come get certified in this, come get certified in that. Anybody could make up a certification. What's really important, though, is to gain skills in a variety of areas and to be able to have a variety of tools and tricks that you can pull from to understand a whole child or the whole student. And so again, that competency is not just a single course or certification, it's lifelong learning. So the first role and responsibility that we will look at that I'll just go ahead and cover here is that of the caregiver or the student. There are the experts in themselves, or caregivers or parents are the experts in their children. And so one of their roles and responsibilities is to share knowledge of students' feeding history and current feeding needs, and this includes food preferences, to provide pertinent medical history. And hopefully they can provide all of that medical history that you need that's important to that child, and to share their goals and concerns, including those cultural considerations. It's really important for teams to listen and validate the family perspective, communicate with them regularly, educate them in return, and share intervention techniques and safe feeding procedures. Maybe you're doing something that they haven't tried yet, and it really makes a difference for the child at home, and vice versa. So, again, looking at them being one of the most important members of our team. So now I'm going to hand it over to Anne, who's going to talk about the roles and responsibilities of the speech language pathologist. So, Anne, go ahead.
Okay, thank you, Jen, and hello, everybody. Thank you for being here today. I'm the speech pathologist that works in the school setting, and so for many times, I'm going to speak to some of these key points here that we are oftentimes the primary contact person when situations arise. Parents may come to us, or the nurse may come to us and say, I received this medical information and I think this is something that you can help the team out with. So that does occur in some settings often. And then one of the other things that we're always doing is looking at assessment and treatment of oral motor and oral sensory needs. And this can include observing a child while they're eating, checking to see if they have an open mouth posture, are they getting good lip closure, something along that line. But I always, and I know Jen is stressing the importance of the team, and I can't stress that enough either. I always work with my OTs to see what we can do to address those sensory needs, because a lot of times they have a lot of information that can really help the child in that area. And then interpreting medical records. If a swallow study results come to a school, it's very important to work with the medical team that did that swallow study. And we might be asked to share the information to a family or staff members to let them know what the safety guidelines are for that child. And we might need to just share some of the strategies. There are generally recommendations and strategies that are shared. So we may have to share those out too with the family and the school staff. Participating in the development of feeding plans goes as a result of the interpretation of medical records. So sometimes food needs to be blended for an individual, or sometimes we need to thicken liquids. And so that might be all part of the feeding plan. And then positioning for a student too, to make sure that they're positioned in a safe manner. And again, working with the PT, working with the OT. The OTs like to work on the fine motor skills of self-feeding. And we may need to take a look at some adaptive tools for the child, and some things like certain cups or lids on cups, or using a straw, or maybe a special spoon, or maybe providing some stimulation in the oral motor area for tongue to palate, to help the child get that elevation so that they can actually move their tongue and get the food back for the swallowing. And some of our kids too, who have physical disabilities, haven't maybe developed the skill as a baby to put their hands in their mouth, or toys or objects in their mouth, so their palate can be high vaulted, which can affect the feeding as well. So taking some of those things into consideration is really important. And then training the team members on implementation of the feeding plan. When I was doing a lot of this in my school, we would go into the classroom during snack time or breakfast or lunchtime, and we would model some of the feeding strategies for the staff. So those paraprofessionals are key people to following through and carrying over on these feeding plans too. And then also working with the families is so huge, and good communication with everybody, the medical community, and the teams who sometimes some of our kids get private therapy. So outside of school, they may be working on these feeding skills because we can't all work on the same goals. And so coordinating with those teams too, to get the carryover so that we're all providing the most safe strategies for the student. So, and looking at preferences for foods too. I've had some parents come to me and say, oh, my child is refusing these foods, and Mealtime is just really hard, but we have to look at that as a communication, not a behavior, because they know what's safe and what isn't safe. You know, we all have that innate skill. So listening to others on the team is very, very important. I think that's it.
Thank you, Anne. Thank you for covering that. I think it's so good to hear from a speech pathologist who's currently working in the school. Carlin, I believe, is on today. Carlin, do you want to take over and cover the occupational and physical therapy roles?
I don't think Carlin is here.
I don't think Carlin is here. Okay, my apologies. I thought she was, but I can very easily cover those. I was looking
Oh
for her.
no, I got
Oh,
it.
Michelle is here. That's what it is. Michelle's got it. Thank you, Michelle.
And thank you. Yeah, absolutely. And Anne was talking about some of the overlapping roles and collaboration that we do with speech and language. And always in open line of communication, as she was talking about, to sort of determine where that, and also you, Jennifer, where that role release happens and who is, so that we're not doing the same things or contradicting or conflicting with each other in terms of where the plan is going. However, occasionally, depending on the level of experience and, as Jennifer mentioned, the level of education that the OT has, they may be the point person for feeding and swallowing, specifically if it is primarily more of a self-feeding issue. Most often, I have found in my experience that it is the speech and language therapist who is going to take on that role, but occasionally there are times that we do. And we will be continuing going through, as this says, ongoing assessment and treatment, especially related to oral sensory needs, also self-regulation. So what are the potentially tactile and other types of sensory processing needs that the child is experiencing around their oral motor, structures that I would say, mouth, tongue, even head and neck sometimes, managing all that, as well as sometimes the ocular motor and visual motor kinds of things that the child is going to come in with that's going to lead into those fine motor skills. Can they visualize where their utensils are and be able to grasp, lift, and bring the utensils to their mouth? And what kinds of things can we do to facilitate that independence for that child? Again, that leads right into implementation of adaptive equipment. Might they need some type of adaptive equipment like weighted utensils, like lighter weight utensils, like the cups that Jennifer suggested. Also, we have plates that are adapted and all kinds of things that we can consider. We even now have something, I don't know how many of you have heard of this. It's called the Obi, which is basically a feeding device for a child that can actually just feed them if they don't have the skills to be able to take the spoon to their mouth or the fork. And then participating, collaborating, integrating with the development of feeding plans with the other team members is always part of what we're going to do, especially as it relates to their IEP and developing that collaborative IEP that we always want to make sure that we have, and training team members on implementation. So collaborating, Obi, thank you, Courtney. Collaborating with other team members and training other team members to provide services that are on behalf of that child. So that they can have carryover that is consistent. And I also want to, does anyone have questions about OT? Because then I can move on to the PT roles. And I love all the people who added what their current team looks like. And I did notice that nobody put down PT on their list. That doesn't mean that PTs aren't on their collaborative teams, but you might not realize that part of the addressing postural or positioning concerns for the classroom also impacts positioning and posture for eating and feeding. So we can depend on our PT professionals and practitioners to help us with facilitating the best possible positioning for accessing and reaching out for their utensils and where they are as it relates to the table and the other devices that they need to access in maybe their wheelchair, but also just in the regular seat. And then also participating in the development of those feeding plans as they relate to that positioning. And again, training team members for implementation, for collaboration, and making sure everyone knows where they should be positioned and how they should be positioned to best access all of the tools and devices and things that they need to be successful. Any other things that people have questions or additions about there? Thank you.
I think that I have learned so much from OTs and PTs over the years. You are some of my favorite people. So thank you for sharing all of that. Our nurse is here today, right, Louise?
Yep, here.
There you are. Okay, Louise, got that one right. Go ahead and share. We're excited to hear what you have to say.
Okay, good. So I'm just going to start by saying that you will not see on my slide that the school nurse is the primary person responsible for pediatric feeding. Again, in the later on, maybe Jennifer or other people can, address that. And I think that that's one of the great things about having this webinar is to understand, what the roles of other people are, because I do think that there are some school districts where the school nurse gets charged with being the primary provider of the implementation of pediatric feeding and the feeding things. But that really, in my opinion, is really not within the scope of practice of school nursing to be the primary person. You heard of all the great things that PTOT and the speech and language person are doing, and I'm listening to them even describing, how we all use our professional language. And I think I know what that means, but that's really not within my scope of practice to really do that. So I think that is important to understand. What is within our scope of practice and what are the responsibilities and roles I do think of nursing and as a school nurse are the things on the slide. So again, the school nurse is going to be this person who might monitor the overall health of the student with pediatric feeding disorder. Again, you're going to have students, as Jennifer has started the sessions at the beginning of the school year talking about, you might have a student with CP, you might have students with neurodiversity, autism, there, and they all have other kind of health conditions. You might have a student who has a food allergy. So those are the type of things, and the school nurse would be involved with that. They might be then writing an emergency action plan, again, for a student particularly that is at risk for anaphylaxis if they get exposed to a food allergen. So that would be the role of the school nurse. Other, the OT, PT, SLP is not going to be writing that emergency action plan. That would be under the responsibilities of the school nurse. Also incorporating student feeding plans into either the student health plan that is a little bit more in depth than the emergency action plan, and then also making sure that the nursing services and the other things that school nursing are doing to make sure that the student is safe, and all their other health needs that impact, and the health needs might be why they have a pediatric feeding disorder, would be written into an IEP under related services. So again, that would be a responsibility of school nursing. If the student would have NG or gastrostomy tube feedings, again, that would be a delegated nursing procedure that would be done by either could be done by the RN or an LPN, or delegated by the RN to less skilled assistants. And so again, you would need to have a medical order, and then that would be I guess we would consider that feeding, and for someone with a pediatric feeding disorder, and that might be the alternative, is that they get fed via NG or a gastrostomy tube. Again, training in how to respond to choking emergencies. Again, I think an SLP, OT, PT would also have some input on that and how you might want to respond. But again, very much see that as a role on responsibility of school nursing. And then also, Jennifer was talking about the the amount of contact and the communication that needs to be among team members and with the medical team members. And again, I think that school nurses certainly can assist with that contacting and getting medical histories, clarifying orders. Again, they would be part of that team that does that. You know, it doesn't have to just rely on the SLP to ask questions and clarify. The school nurse could certainly help with that. So thank you.
Thank you. And again, I just want to reiterate from the last time we met how important the school nurses are. They really can be a lifeline for you between families and other medical practitioners. Louise, I'm wondering, have you seen at all when you're talking about choking, because I know that this comes up a lot in the outpatient settings, and just take 1 second. Have you seen the D-choker in the schools at all? It's a device that is supposed to suction out food. Sometimes families will, again, like feel safer if you have that there. So just an awareness again as we respect that families all have these different needs and feeling like, well, this might be the device that I want you to use. That there are actually devices out there now that companies are selling for choking. Have you seen that at all, Louise?
Yeah, and I'm going to be very careful about what I say about that as far as legislation goes. DPI has testified on this, that it's up to the school district to determine if they would like to use some that. There are no standardized protocols on how you would utilize those.
Right.
And so if a school district was doing that, and that probably would then fall on the school nurse, you would be going out on a limb and making your own professional determination and not have any support from any credible organization on how to use that. So again, I think schools have to determine how that. Yes, there are school districts that have been given the anti-choking devices to use. And again, it's a decision that school districts have to make on their own if they're going to incorporate that, because right now they're not approved for use in schools. They're not regulated for use in schools. They're licensed or regulated. I shouldn't use the term license, regulated to use at the hospital bedside, so not necessarily school. So again, being careful about that. And again, DPI would just say, make sure you make decisions, and it's really a district decision at this time.
Good. Well, I'm actually really glad I brought that up then, because I think that that's something that, again, the LifeVacs, yeah, they have all sorts of different names out there. So thank you, Louise, for giving us that very thoughtful response there. Things are always changing. There's new devices out there all the time. So let's talk about then the roles and responsibilities of educational individuals, such as our special educators, our regular educators, and our paraprofessionals. These individuals will be responsible for implementation of feeding plans, ensuring fidelity, making sure that you're doing it correctly and consistently, following the health plans, which are set in place by the family and the nurse and the team in general, and then reporting any of those changes. Again, sometimes even those subtle changes can make such a big difference. And then on the next slide, I know that Maggie, our dietitian and nutrition expert, is on the road, very busy this week. But she did reiterate that again, that ensuring food is prepared and presented per the feeding plan is something that they are responsible for. And I want to revisit something that we've talked about in the past, which is you can make documentation, or you can document and make changes to an individual's plate, so to speak, that is served to them based upon the IEP or the 504. And what we have written, it doesn't have to go all the way through a doctor and then back to you if that's what the family is saying that the child eats. We have a lot of kids who are autistic who have some very, very specific food preferences, and really putting non-preferred foods in front of them can be quite aversive. And so we want to make sure that we are presenting foods to them per whatever their feeding plan is. All right. We cannot forget the roles and responsibilities of the administration. Again, they are there to support team members working with students with PFD. We would be hopeful that your administrators can serve in the role of a mediator or liaison is needed, and that they could be aware of feeding and health plans for students with PFD, certainly bringing that to their attention as needed. I have had a wonderful opportunity to work with many administrators who really, especially like principals or even higher level special ed directors and whatnot, who will actually come to IEPs for some of these children because they know that this is such a unique situation and they really do want to make sure that they are ensuring success and safety. All right, so a couple of thoughts on collaboration between school and medical teams. First, make sure that you have signed permission or whatever appropriate paperwork there is for your district. I know, for example, I work with the Racine Unified School District a lot, and our USD has a very specific form that I need to fill out to talk to them, and then they will call me back. Think about the why. What questions or concerns do you have related to the student's health or nutrition status? I think it's always important for us to have that list of questions when we go to the doctor, right? Keep a little notebook and to have those questions ready because you will be having a short amount of time to work with these individuals, talk with these individuals, since you're probably on different schedules and playing phone tag or email tag. Think about who you want to discuss these questions with. Determine the most appropriate medical provider. A tip that I use is it's usually safe, so to speak, to start with the primary medical doctor, to start with the child's pediatrician or whomever they see. And if they want to refer you on further, they certainly can. And I love to give this tip because sometimes speaking with nurses can really get you very far versus just leaving a message for the doctor because the doctors are very busy. So if you can talk to the nurse, tell them exactly what's going on. Lots of times they can grab the doctor between patients. They can have the phone call back to you and have that communication directly with the doctor themselves versus you having to wait for the doctor to call you back. Anybody that you're talking to in terms of a medical personnel, and I hope that these individuals are giving the same thought to you as far as leaving available times for return calls is very helpful, and offering options for communication, right? Email, cell phones. I know I have a desk phone, but I never use it. I'm always like, look, I'm not at my desk. Call me, text me, carrier pigeon, whatever works for you. Let's just connect. Okay. Collaboration between school team members. How do you maintain communication with caregivers at home? It's a question I have for you. What do you do? Because the kids come to school in a bus or they're transported via a caregiver, or maybe they're coming from a before or after school care program, or maybe they are walking because they're within the walking range. So what works for you? Okay, so email, I see. Google Doc with the family. I love Google Docs. Yeah, you can see everything in real time. How else do we? So Luis, Luis is leaving some information in there about the Life VAC. Thank you for that. I'm really glad I brought that up because it seems like that is a very hot topic and something very specific that they should be aware of. How else are we communicating with families? You know, it's so different in the outpatient setting where somebody brings a child and somebody picks a child up and I get to see them. I can pull them into the session if I want. Is anybody using virtual meetings, virtual options? Phone calls are great. Notebooks are great. Yeah. I've really been doing a lot of virtual meetings with families. Love virtual. Yeah. I think that works out really well because nobody has to go anywhere except to a computer screen, and you can do it very easily on your phone. I find that is very, very useful. Phone calls we have in there. Yeah. How about as a team, how do you schedule time for regular and focused interdisciplinary collaboration? We talked about how to build a team. We talked about how teams work. We talked about that role release and all of these important things that we do to mentor and train. But how do you schedule time for that? It takes time. So throw it in the chat. What's working for you in your school or in your district as far as making sure that you save some space for these opportunities, for these discussions, and for these important team meetings to happen. So let's see. I'm wondering if people are using virtual too. Include this collaboration time and program modifications and supports for school personnel on the IEP. Dawn's the expert, so I love that. Write it in the program modification of the IEP. Yeah. And then making sure everybody sets a calendar time or something, right? Good. Anybody else have any ideas related to how they are collaborating, finding that time? Gosh, I hope it's not like over your lunches, right? You're like, oh, we'll meet at lunch. Like it's so important to find and really protect those spaces. PLC. I am interested in what that means, Michelle. I'm trying to pull that word apart and I don't know what it is. So I'd like to know professional learning community. Oh, okay, great. I love that. I'm learning as much as you all are. Okay, good. Any other thoughts in that? Okay, great. All right, well, we're running right on time. I just love that for me, for you. So let's chat for a minute. Throw some more questions in the chat. What else are your thoughts on being part of a team, or what team questions do you have?